Can they hear me?
Yeah, you're on.
All right. Well, good afternoon, good evening, good all the things. I am Dr. El Sayed, aka Dr. Jamal. I am one of the emergency medicine residents at Freeman Health System here in Joplin. We got the opportunity to present lots of topics to you guys, and today's topic is going to be shock. Uh, Personally speaking, it's one of those topics that I am very, very passionate about. I never realized or understand the concept of shock until I saw you guys working behind the scenes, taking care of people who are really, really, really sick. And they present with variabilities of vital signs and variabilities of sickness. And you got to determine who is really sick and who is not sick, who really needs to be urgently and emergently coming to our emergency department to actually take care of them. So the definition itself of shock is really not one of those easy definitions, and it took me some time to even understand it. And one of the things that I realized about the definition itself is that it actually evolves. So it's not one definition that we got stuck with since the 1990s. And I swear to God, it is amazing how much development and improvement on the definition itself that we have obtained and gained knowledge about it. And our comprehension of the definition of sepsis itself and the definition of shock has improved over time to the point that we now have categories. We have requirements for it to call it a shock. We have an understanding of how the pathophysiology works behind it and what actually is shock. So I will take you through it one by one, and I have like a couple of slides here to actually walk you through the definition itself. So my objectives from this presentation is going to be an introduction. I'm gonna like introduce it a little bit, and then I'm gonna walk you through the differentials of shock. And I wanna focus on the differentials because differentials and types of shocks, they are very, very different from each other. And we need to understand the differences of them in order for us to take care of our patients before you guys present them to us. As soon as you present your patient to me and you mention the word shock, then I will be 10 out of 10 more focused with you because I know that you understand what that means. And then the pathophysiology of each and every single type of shock. And then we're going to go through the signs and the symptoms, what things that you should be looking for. And then the diagnostic tools. The diagnostic tools part, that's my part. That's the part that I do in my emergency department to make sure that I can evaluate and actually confirm the fact that the patients are having shock. And then we're going to go through some of the management strategies. That's also part of my work. How do I manage shock in the emergency department and where do they end up going? And then after that, we're going to do some little cool case studies. We're going to do some teaching moments with those cool studies. And then after that, we're going to do some epidemiology and biometrics and biostatistics if we have time at the end. And then we're going to conclude it. Okay? So the definition: an abnormality of the circulatory system that results in inadequate organ perfusion and tissue oxygenation. I like the fact that now the definition has two parts. The first part is the inadequate organ perfusion, and the second part is the tissue oxygenation. So the word perfusion and the word oxygenation, these are the actual criteria for the definition of shock. This definition guides the trauma team in the diagnosis and the treatment. Diagnosing trauma relies on the synthesis of clinical findings and lab tests. So it's all about your clinical findings. It's all about what you see on the patient with their vital signs. And then you come to my emergency department. I get some labs to confirm your initial findings. Now, what is the impact on patients? Patient management responsibilities begin with early recognition of the presence of shock. That's where you guys come in. I appreciate so much when people come in my department and you guys are telling me, hey, we have a shock patient. Hey, this patient is going to shock. This patient is already in shock. Early recognition, not from us, it's from you. As soon as you early recognize that, you are the first step in saving that patient's life. Initiate treatment immediately and identify the probable cause, because in order for you to initiate the appropriate treatment for the appropriate shock management, you need to understand the probable cause of that shock. The patient's response to initial treatment, coupled with clinical findings, usually provides sufficient information to determine the cause of the shock itself. So you are going to early recognize it. You are going to early start treating, and then you're going to see either an improvement or similar kind of presentation. And that is good news. So you don't necessarily need to find an impact right away. You don't necessarily need to find a change in the blood pressure right away. Maybe you will give them just enough time for them to arrive to our department, and then we will take it forward. But without your intervention, without your early recognition, guess what will happen? The patient will actually deteriorate. And that's where I appreciate you guys so much for how much work that you do behind the scenes. So, types of shocks. There are so many ways that you can differentiate the types, and you can go through it in very, very multiple variables. My approach to types of shock will be hemorrhagic / hypovolemic. I always believe that these two types are kind of the same thing. And then after that, I will say non-hemorrhagic. So you're either losing blood or you're not losing blood. That's how I look at it. You can always look at it from every single different aspect. It's up to you guys. My non-hemorrhagic categories, then, it will be subcategories into cardiogenic, distributive, neurogenic, septic. And then obstructive will be cardiac tamponade, tension pneumothorax, pulmonary embolism, and then finally anaphylactic. So I'll walk you through each and every single type, and I'll tell you what happened in medicine that improved over time and how that applies to you guys. So my first type is hypovolemic shock. So in the hypovolemic shock, that is basically the most common type of shock that you are going to witness. And I understand people are all about sepsis, people are all about UTIs, people are all about infections, but in reality, a lot of older generation, a lot of older people, they actually struggle from hypovolemic shock first before they go into septic shock, before they go into infections and all that. We're gonna go through it, I swear. I hope you're not overwhelmed. So the first type will be oxygen delivery is diminished by a loss of circulatory volume resulting in decrease of preload. So preload is basically the volume before it reaches the heart. Once that volume reaches the heart, it becomes the contractility. And then once that volume is out of the heart, it's called afterload. Very, very simple terms. Now, a compensatory response mediated by the sympathetic nervous system leads to an increase in the systemic vascular resistance and heart rate. So imagine, I have 5 liters of blood. I lose 2 liters of blood. What is my body going to do? My body is going to contract. So that means every single vessel in my body is going to actually contract, actually constrict. That's the word. And when it constricts, you increase the systemic vascular resistance of your system. So once that system increases, your body is going to do a couple of things, a couple of signs and symptoms that we're going to address. But I want you to understand how the body works and how it responds to loss of volume. Whether it's dehydration, that means loss of volume intake, or you're actually bleeding. Now, most common causes are the hemorrhagic, that's the one that you guys see, gunshot wounds, all the things. And they are internal or external. So you might have an internal bleed from an accident. You might have an external bleed from a gunshot wound or a stab wound. In reality, any hemorrhagic shock, you need to think about what the body is doing as a result of losing that volume. And then you got severe dehydration. You got fluid loss from GI. I love that. A lot of old people who have several episodes of diarrhea and vomiting, and then you look at them, they look like death. That's exactly what that is. They lose a lot of volume. You don't necessarily need to lose a lot of volume from blood. You can easily use it from your GI system, whether it's vomiting or diarrhea. And then you got urinary tract and you got skin. Maybe you're peeing a lot. Maybe you're actually sweating a lot. These are also common things that can happen from hypovolemia that you need to keep in your mind. Now, the second type that we all like is the cardiogenic shock. Myocardial infarction, your favorite, STEMI. You get a STEMI alert, you send it to us, we look at it, we'll be like, oh shit, that's STEMI. I am activating my cath lab. You guys are going to walk into my emergency department straight up to cath lab. You're not going to even be in my room. So for you to recognize what a STEMI is, for you to recognize that this patient is actually having a myocardial infarction and needs to go straight to cath lab, this is what I call an early recognition. This is what I applaud you guys so much for understanding and applying on daily basis. And the best part about it, they don't even have a chest pain. That is the best part. They'll be like, I don't feel too well. and I woke up and I feel funny. These are actually the symptoms that we got. I literally got a STEMI yesterday, and he did not have any chest pain. And it was your classic Tom Stoon STEMI alert. And all he felt was feeling funny. That's all he said, nothing else. He's a little bit nauseous, but that's about it. No chest pain, no shortness of breath, nothing. He just feels funny. And yeah, it's actually true. You don't necessarily need to present with classic symptoms. And that's what the saving life opportunities comes in when you guys recognize it on an EKG. And then you got a suspect, a blunt cardiac injury, when the mechanism of injury into the thorax involves a rapid deceleration. And that's where the mechanism of the car accident is very, very important for us, for you guys to actually explain it to me. Tell me that the airbags were deployed. Tell me that they were wearing a seatbelt. Tell me how bad the car was damaged. If you took pictures, show me the pictures. I want to understand exactly how that mechanism happened, because that mechanism will provide me with a lot of the information that I need to recognize cardiogenic shock. Left ventricular fails to deliver oxygenated blood to the peripheral tissues due to variances in contractility, preload, afterload, and right ventricular function. These are the definitions that we went through. Any part of the heart can have a myocardial infarction. Any blood vessel in the heart does not have enough perfusion, does not have enough oxygenation, will actually lead to a myocardial infarction. You can have an NSTEMI. You don't necessarily need to have a lot of ST changes. You can just have ST depressions in some of the leads with a little bit of elevated troponins, and then we call it an STEMI. Next is neurogenic shock. These are not so common, however, they exist, and they exist with very, very, very bad traumas. And very simple traumas can happen too, is just a fall. Somebody was fixing a bell on a church, somebody was fixing the roof, they slipped, they fell, and now they are in neurogenic shock. How did that happen? Cervical and upper thoracic spinal cord injuries can actually produce hypotension due to a loss of sympathetic tone. So now the idea here is that you get a blood pressure on this guy who just fell, and then the blood pressure is low. The first thing that you will do is blast them with fluids. Guess what? They are not losing fluids. They are not actually in a state where they need fluids. What they need is their sympathetic system. Sympathetic system, that's your flight. That's your flight and go. That's when you are fighting. That's when you are terrified. That's when your system is all on the high level. That's when your heart rate is up. That's when things are adrenaline is kicking in. When that sympathetic system is kicking in, it provides you with necessary variables in your system in order for you to survive. However, with a neurogenic shock, that sympathetic tone is gone. So now your body is hypotensive, you're bradycardic. What is going on? Especially after a fall, you really need to think about neurogenic shock. This compounds by the physiologic effect of hypovolemia, and then you got the hypovolemia compounds the physiologic effect of sympathetic denervation. So you lose the sympathetic system, and then you become hypovolemic. You get the concept? Equals hypotension without tachycardia or cutaneous vasoconstriction. And that's the part, the vasoconstriction part, that's the part where you don't have. So you got what you call vasodilation. When you have vasodilation, you lose that blood pressure. So you think that you're losing volume. That's exactly the concept of neurogenic shock. Okay, septic shock. Now, this particular definition is very intriguing. I like to use that picture a lot. I'm going to go through septic shock now, but I want you guys to understand that particular picture. It's one of my favorites. So what they do here is that the bacteria comes in, and then you got your little white blood cells, and then they release what they call cytokines, right? That's part of your immune system. Those cytokines actually cause leaky vessels. So when those vessels leak, you start having low blood pressure, and that's part of the vasodilation concept. And then it affects your brain, it affects your lungs, it affects your heart, liver, and kidney. So what does that mean by that effect? So for brain, you can have altered mental status. It's like, this patient is altered. Are they demented or are they altered? That is always a challenging concept, especially here with jobless population. However, with that being said, you need to understand the definition of what is the baseline and whether they are actually altered because of an infection that is affecting their brain from the leaky vessels. Are they affected their lungs? Are they having shortness of breath? Are they having shortness of breath because they just have COPD exacerbation and that's just one of their COPD exacerbation? Or are they having shortness of breath because of an actual infection that is causing their lungs to increase in the breathing rate? Heart, you're tachycardic. This patient is literally having a tachycardia to the point that they developed SVT, to the point that they're developing AFib, to the point that where heart is no longer able to function the way it should be functioning. And then your liver, what happened? You get into a liver shock. Literally, your liver enzymes are going to be up through the roof. Kidney, same thing, AKI, acute kidney injury. Those are the symptoms and the signs that we actually see on the lab work that we're like, all right, that's going to be an easy admit for me. But the idea here is that where they're going to get admitted, that will be a question for later. Cardiac tamponade. So my favorite part of the cardiac tamponade is the ultrasound skills that we use in the trauma bay. As soon as you get the patient in, as soon as I go through my ABC protocol, the first thing that I do is grab that ultrasound and do my fast exam. As soon as I see that picture that you guys see on the ultrasound, this is it. This is my go-truth moment when I actually pick up my pericardiocentesis and I actually put a needle in somebody's chest to pull the blood out of their pericardial area, where I can actually release some of the pressure of the heart and then allow the heart to continue pumping. And that's when they go to CVICU or straight up to surgery. Depends on how complicated that situation is. So some of the definitions of the ultrasound itself, you guys can see. As soon as we have the ultrasound probe on the top of the picture, the first thing that we see is the right ventricle. Why? Because the right ventricle is the biggest anatomy in your heart. So as soon as you put the ultrasound probe on the heart, you are going to see the right ventricle. And then after that, behind it is the left ventricle. And then up, you're going to see the left atrium. And then the little black thing that's called effusion, that's the part that I'm looking for. That's when I put the ultrasound in, I am looking for that. If I see an effusion, and then I see low blood pressure, I see low blood pressure and I see high heart rate, that means your body is under an actual shock. That's what we call a cardiogenic shock. That's what we call a tamponade. Next will be tension pneumothorax. So that one is very interesting because as soon as I get the chest x-ray, I won't be able to see the fact that your lungs are collapsed. I got a lot of people that I got a chest x-ray on them and I did not see a lung collapse. And I'll be like, oh yeah, I'm not appreciating a pneumothorax, right? Or I'm not appreciating a lung collapse. However, when I get my ultrasound and I start actually looking for the heart, and it literally happened like, I think 2-3 months ago, we had a trauma. We got the ultrasound probe. We were looking for the heart. I could not visualize the heart. I was like, where the heck is the heart? I can't find it. And then I realized that this patient developed a tension pneumothorax, developed a huge pneumothorax that was not seen on a chest x-ray. That's what's amazing. We did not see it on the chest x-ray. We saw it on the chest CT. And that's when we realized that the lung collapse itself created an absence of volume. So we could not visualize the heart appropriately. And that was very, very cool. How do I know that this patient is having a tension pneumothorax on ultrasound? I look for the lines. If I see those lines, which are called, what do they call it here? Absent of lung sliding. So when the lungs are no longer sliding, that's called pneumothorax. That means the lungs are not actually expanding and decreasing, expanding and decreasing. That's kind of the concept. So absent of those lung sliding will tell me that this patient actually have absent pneumothorax. And yes, that's true. The patient that I couldn't visualize the heart, they did not have any lung sliding on that section. Then we have anaphylactic shock. The diagnosis of anaphylaxis is always clinical. You see it, you know it. So consider it when involvement of any 2 or more body systems is actually observed. So a complaint of a lump in my throat, hoarseness, or life-threatening laryngeal edema in a patient with symptoms of anaphylaxis. The faster the onset of symptoms, the more severe the reaction is. 1/2 of the anaphylactic fatalities actually occur within the first hour. You get a patient who was just in a Chinese store and they were having pho, and then all of a sudden they started developing rash and they couldn't take the breath and they feel like their throat is swelling. Yeah, that is an allergic reaction. Literally happened yesterday. Now, I want to walk you through each and every single pathophysiology of those shocks so you can understand it better. So when you see it, you know it. So the definition of hemorrhagic shock actually did improve over time. And I like the next slide because the next slide is going to show you what improvement happened. So initially, The definition of hemorrhagic shock was based on 3 different criteria. And those 3 criteria, one of our trauma surgeons in Freeman love to ask about them. Why? Because they're so essential, very, very essential. If you recognize them as a medical person, whether you're a doctor, whether you're a nurse, whether you're an EMT, if you recognize those 3 things, you actually nailed it. So the first thing is the hypothermia. Lose of temperature itself will lead the body to go through an actual derangement of metabolic derangement. Next, you will have coagulopathy. So the fact that you're losing a lot of blood and the fact that the blood is trying to compensate for the loss of blood will cause you to have an actual coagulopathy. And then because of all that loss and because of the loss of temperature, you're going to have an acidosis. So acidosis, coagulopathy, and hypothermia. That is your death. That is literally the triad of death. If the patient in my trauma bay developed those 3 things, I cannot survive. I cannot get that patient back, despite what I do. So how do I save him? I stop this triad from happening in the first place. I get lots of blankets. I make sure that I do 1-to-1-to-1 transfusion when it comes to fluids, when it comes to packed red blood cells, when it comes to fresh frozen plasma. The balance that I create will stop them from having the coagulopathy. And then the acidosis, I make sure that I change and I fix their metabolic derangements. If they're losing potassium, if they're losing oxygen, if they are actually losing a lot of blood that cause them to have acidosis, and I give some bicarb to balance that. It's all how I prevent them from getting into that triad. Now, we change that triad a little bit so you can understand it better. So the word acidosis, we expand on it and we call it metabolic because I want you to focus on it. It's not only the pH that I get as soon as I get a point of care pH and then I say, oh, that's acid, that's done. No, you need to expand your definition a little bit. It's all about the metabolism of the body itself. And then we added the hemodynamic because guess what? Hemodynamic is also important. If the patient's MAB is below 65 and it's like trashing at 40, then you'll be like, oh, damn, like I need to transfuse faster. I need to focus on the hemodynamic stability itself. And then hematologic, that's where coagulopathy came in. That's when we look at the hemoglobin, the hematocrit. We are expanding the definitions of these things to understand it better. And then I added heterogenic, and I love the fact that they added heterogenic in that concept because guess what? It's your job. When you stop the bleed, when you give fluids, when you provide blankets to that patient while you're actually transporting them in the ambulance, when you're driving fast like crazy to get that patient to my trauma bay as soon as possible, when you fly those patients, that's your contribution to that triad. That's when you make it better. That's when you save your patient. Cardiogenic shock pathophysiology. I'm so sorry that this picture is a little bit blurry, but it's very simple. You got heart rate times stroke volume is equal to cardiac output. And that is the basic definition of how the body works. You got your preload, all the volume of the blood before it reaches the heart. You got the contractility, that's when your heart is pumping. And then you got the systemic arteries when they constrict and they cause the blood to go into your tissues and creates the perfusion that we're looking for. So any abnormalities of any of them, if you have increased heart rate, if you have low stroke volume, you are going to have a low cardiac output. That's kind of the concept. You have high heart rate, you have high stroke volume, you're going to have a low cardiac output. So it's a very simple equation that you create in your head, and then you balance that equation accordingly to whatever findings you get. Now, the profound depression of myocardial contractility leads to the catastrophic decrease in cardiac output. And that's where you have decreased contractility. And then the blood pressure, what is it going to do? It's going to be impaired, perpetuating further coronary ischemia and contractility impairment. So now your heart is under a lot of stress. It's under shock. Now, the activation of the sympathetic system, that will be the compensatory mechanism, will lead to improved coronary perfusion at the cost of increased afterload. But if I increase contractility too much, I increase vasoconstriction too much, I am actually compromising the perfusion. And that's where it gets confused because the body is trying to save itself, but it's not really doing it. That's where we come in as EMTs and doctors to actually save that equation from failing. Tachycardia increases myocardial oxygen demand and subsequently worsen the ischemia. Imagine you're pumping too much to the point that the blood itself to the arteries of the muscles of the heart are not getting enough oxygenation, are not getting enough perfusion, and they're actually dying. With the neurogenic shock pathophysiology, you got a primary injury to the is a direct damage to the axons and the neural membranes. So it's the actual neurons that gets damaged from that fall. This old poor man who actually fell and damaged his brain or damaged his spinal cord. And the intermediolateral nucleus, that's kind of fancy word for where it is in the spinal cord, the lateral gray matter, and the anterior root that leads to disrupted sympathetic tone. That's just basic anatomy. Secondary spinal cord injury occurs hours to days after the initial insult. That's why you guys put on your precautionary C-collar. That's you want to make sure that the patient is stable enough, not moving a whole lot, because you want to prevent further injury from happening. The secondary injury results from vascular insult, electrolyte shifts, and edema that actually lead to progressive central hemorrhage necrosis of the gray matter at the injury site. Now, septic shock. Septic shock, the organisms itself or the bacteria itself cause a direct injury that can provoke hemodynamic collapse. The host immune response results in injury and can also result in a hemodynamic collapse. So you got bacteria and you got immune system. They're fighting each other and they are literally driving themselves to death. With the development of hypotension, tissue oxygenation, and demand is not met. So what happens? Metabolic derangement. Now you shift into that triad that we were talking about earlier, the coagulopathy, the acidosis, and the metabolic derangement. That's exactly what happens. A shift from aerobic to anaerobic respiration with ensuring lactic acidosis occur. That's why from our emergency department aspect, the first thing that the nurse comes to me, she was like, hey doc, do you want a lactic? I'm like, yes, I want a lactic. Of course I want a lactic, because lactic acid will tell me if the cells are so under attack from the bacteria to the point that they're no longer getting oxygen, to the point that they're shifting to anaerobic stage. And when they shift to anaerobic stage, the body starts consuming lactic acid and start producing lactic acid, because that's the power energy from the mitochondria. And the lactic acid will be my key to know that, whole crab, this patient is dying. Now, obstructive shock. It occurs as a result of a decrease in the venous return or cardiac compliance due to an increased left ventricular outflow obstruction or marked decrease in the preload. So you get it, you can get it both ways. You can get it because of blood or fluid accumulating around the heart, or you can get it because of an obstruction itself, whether it's a pulmonary embolism or tension pneumothorax. It can be classified according to the location of the obstruction in the vascular system in relation to the heart. So it depends on where your obstruction is, depends on how you're going to get the shock. Common to all these obstructive states and the often rapid, massive drop in the cardiac output and blood pressure. When you see it, you have to early recognize it in order for you to make the appropriate intervention. Whether you're going to stick a quick needle in his chest to make sure that you relieve the tension pneumothorax, whether you're going to get a quick needle into their heart to make sure that you relieve that blood from their pericardium. The pathophysiology of anaphylaxis. It arises from the activation of mast cells and basophils. So these are basically your part of your immune system that is responsible for allergic response. The mechanisms involving cross-linking of the IgE and aggregating of high affinity receptor responses to the IgE itself. So when you think about the IgA, the IgM, the IgG, these are all basically antibodies that the body produces in certain areas. IgE is the one that is responsible for the anaphylactic shock that you witness on your patient. The quick release of perform mediators, including histamine, and then you got your tryptase, and you got your proteoglycans, which all get activated and cause further harm. They stimulate vasodilation, they increase vascular permeability, heart rate, cardiac contraction, and glandular secretions. So if you think about them, you got vascular permeability, that means you got hypotension. You got heart rate, that means you got increased heart rate. And then you got cardiac contractions and glandular secretions, and that's when you get all that swelling that we notice on the patients. That's when you get the rash in their skin. So I like those tables a lot. They actually came straight up from Tentinelli, one of our favorite emergency medicine book. And in that particular thing, it says here, you got urticaria. That's basically the flushing, the edema of the lips, the tongue, the uvula. You look at their mouth. Look at their mouth. You don't have to wait until they come to my emergency department for you to shine a light in their mouth. Just look. Ask them to open up their mouth, stick their tongue out, and look at that uvula. You see it swollen, you see it red, and you don't see the rest of the palate. Guess what you're gonna do? You prepare for intubation. You get them intubated. I love how Dr. Henry mentioned the fact that if you notice an inhalation injury, because inhalation injury can actually cause you to have swelling and cause you to need to be intubated. Get on it. And then you got your respiratory distress, hypoxia, you got a hypotension or cardiovascular collapse, or basically a bunch of other symptoms. You got skin mucosal involvement, respiratory compromise, hypotension, persistent GI cramps, vomiting, diarrhea, all the things. Consider anaphylaxis when patients are exposed to a known allergen and develop hypotension. Oh, they didn't know there was peanut butter. Oh, they didn't know they are allergic to tomatoes. For some reason, some people are actually allergic to tomatoes. And I was surprised. They had a salad with tomatoes and they developed an allergic reaction. It's like, what? Tomatoes are nice, but no longer are nice with those people. Clinical manifestations. So with ENT, you think about throat fullness, you think about tongue swelling, you think about the uvular edema that we talked about. For a respiratory perspective, look at their stridor. Look at how much they're actually trying to breathe through all that swelling. For cardiovascular, look at your blood pressure. Are they having an actual chest pain? Look at their skin. How bad is the flushing is happening? Is it happening to the point that they're losing it and you need to push that adrenaline? You need to give them that EpiPen to save their lives? Yes. Neurogenic. Are they having a headache? Are they actually seizing because of the allergic reaction? I've never seen one, but apparently it is there. So always have a very open mind when it comes to seizures. It's like, oh yeah, they're having a seizure and they're having history of seizures and they're on Keppra and they're not taking their medicine. Great, but is it actually happening because of an allergic reaction or is it happening because of neurological problem? Have that open mind. So what do? Airway protection, always airway, always oxygenate, always put that oxygen on. Never stop yourself from putting a tube down their throat if that's the one thing that is going to save their lives. And then decontamination. Decontamination is very important. I actually noticed it with you guys because you start like taking all their clothes off, you start putting them in a new sheet, you start putting them in new things, and that's part of the decontamination process that I truly appreciate from you guys. Identifying the causative agent and terminating the exposure itself. And then you got your epinephrine. That is your treatment of choice. And you can actually give it every 5 to 10 minutes according to the response or if they relapse again. Second line of treatment, that's when we come in. That's when we blast them with steroids, Benadryl, all the things. Sometimes we even give him inhaled bronchodilators like a DO treatment. You guys can give that en route, which is also very helpful to the patients. And then we are going to go to the diagnostic tools part. That's the part where the diagnosis is my part. That's when I come in. The physical examination is very, very focused on diagnosing immediately life-threatening injuries and assessing the A, B, C, D, E's. That's basically airway, breathing, circulation, and then I look at their overall disabilities, and then I look at their overall exposure. I need to get every single piece of cloth out of them, and I need to look at every single part of their body, including their back. And then baseline observations to assess the patient's response to the therapy, and then repeated measurements. Get your vital signs. Give them every 5 minutes, give them every 10 minutes, give them every 15 minutes, depending on your situation. And then urine output and the level of consciousness, they are your essential tools to know if they are actually responding to treatments or not. Are they peeing? Are they actually aware and alert and oriented? Because as soon as they lose that consciousness, as soon as they don't give you any urine over the next 12 hours, that's bad news. Now I use my ultrasound. So point of care ultrasound or FAST, that's basically a focus assessment tool for ultrasound to search for the cause of the shock. I want to know what's up. I put the ultrasound on their belly. Are they having free fluid? Are they having free blood? I put the ultrasound on their lungs. Are they having tension pneumothorax? I put the ultrasound on their heart. Are they having blood around their heart? These are all things that I quickly do. I can do my whole FAST exam in literally 90 seconds and know the cause of my shock. And then boom, EKG right away, get those cardiac enzyme panel to make sure that they're not having a STEMI, to make sure that they're not having an NSTEMI. And then I do my full x-rays. Are they breaking a bone? Were they falling? Were they actually in a car accident with an obvious deformity? So I get my chest, abdomen, and pelvis right away. And then long bones, depending on the situation. And then as soon as we finish the stabilization, our trauma surgeons are very, very, very keen about taking those patients straight up to CT. Sometimes I get delayed. Sometimes I got lacerations everywhere and blood everywhere to the point that I need to suture the blood first. I need to suture whatever needs to be sutured in order for me to stabilize the patient. And then after that, take them straight up to CT. That is a delay of care, but it is what it is. So you got to stabilize and then you got to take them straight up to CT. And then your basic head and cervical CTs needs to be obtained so you can clear the cervical color that you guys put in. And then after that, I'll get my blood work. I need to make sure that I get a type and screen. I get a CBC, I get a CMP, which is a complete metabolic panel. I add a coagulation, a PT-INR to make sure that are they going through coagulopathy? Is it so bad to the point that I need to fix it? And then I get my EBG, which is basically blood gas. I want to make sure where their pH is. I'll get a quick point of care glucose. Always get a quick point of care glucose first and foremost. I can add a ProCal to look for pneumonia, to look for signs of infections that might be causing the sepsis. And then I get calcium, magnesium, and of course, my favorite is lactic acid. Now, how do I manage what is going on with my shocks, right? So I establish the airway, I intubate, I make sure that RT is on board, I make sure that I put them on the correct ventilation setting. I make sure that they're stable enough for the intubation, because I appreciate doctors who jump into intubation right away as their first line. However, you have to remember something very important. When we intubate, when we do an RSI, we are taking the one line defense of the patient. We are pulling that carpet away from them. So they're no longer having sympathetic system. They're no longer able to breathe because I literally paralyze them and I literally sedate them. By giving them those two medicines, you have to make sure that you get that tube in the right place in the right time so they do not decompensate on you. So it's a lot of risk. It's a big risk. So just make sure before you do that, you are set yourself up for success. Now, controlling the work of breathing by mechanical ventilation and sedation allows adequate oxygenation and an improvement of the hypercapnia. The goal is to decrease the work of breathing and improve survival, because if they are so under attack of their lungs with all the capillary leaks, with all the pneumonia, with all the infection, whatever is causing the lungs to deteriorate, even from just a pulmonary contusion from the car accident itself, I am protecting their lungs by giving it a break. So when I put you in a ventilation, when I put it you down your throat, what I am basically doing is that I'm giving your lungs some time to rest and heal so it can breathe better eventually. And then the ventilation machine is doing all the work of breathing for me. So what I do is optimize the circulation. How do I do that? I either get a peripheral access, and if the peripheral access is not able to be obtained, then I go for the large bore peripheral venous access. And then if not, then I get my IO. Hey, you got to drill, you got to drill. I mean, this is just part of the process. You got to save lives. And if you can get that peripheral access, then get your intraosseous access. Get a little gun, push that needle in whatever necessary places you got in. You got anterior tibial, you got shoulder, you got long bones. You can hammer into those long bones and get that access and push those medicines in. Now, if the circumstances prevent you from the use of the peripheral veins, then that's when we come in as emergency medicine residents, as general surgery residents. The first thing that they do is they set up themselves for a central line. And a central line, that's basically more of an access. I can put it in the internal jugular vein. I can put it in my femoral vein. Whatever access I can get and I can put my hands on it, I can put down there the line and make sure that they have access for more fluids, more blood. Now, assess the patient response to the fluid resuscitation and identify the evidence of an end organ perfusion and tissue oxygenation. Now I stabilize the patient. I intubated. I put the central line in. I put the arterial line in. I did all the things. What am I going to do next? Am I going to give them pressors? Am I going to give them fluids? Am I going to give them blood? All these decisions I have to make according to the clinical picture and what you guys presented to me in the first place as soon as the patient arrived. Observe the patient's response during fluid administration and base further therapeutic and diagnostic decisions on the response. I'm not just doing it for the sake of doing it. I am doing it just enough to see enough response. Once I see enough response, once I see stability, then I can move forward with my patient's management appropriately. It's very, very careful consideration when it comes to trauma. It's very careful consideration when it comes to sepsis or any type of shock. So always keep that in mind. It's a really big deal, and a lot of people are not well educated on it. They're not well informed with the process of it all. So I hope that is helping you guys a little bit to get an insight of what's going on. Vasopressors are used when there has been an inadequate response to volume resuscitation. I'm giving fluid, I'm giving blood. The body can handle it. Why? Because there's not enough sympathetic system. What do? I give them the pressors. So that's basically a type of adrenaline. It's either called norepinephrine or epinephrine. Either way, it doesn't matter, because what you're doing is you're giving that adrenaline, you're causing increase of sympathetic system, you're causing increase of vasoconstriction, and then boom, your blood pressure is going to go up, your MAP is going to go up, your perfusion is going to get better. Not so much though in the little extremities, because unfortunately, one of the major side effects that we get from pressors is that their literally fingers starts falling off, because you're constricting too much to the point that the little extremities are not getting enough blood supply. You're vasopressing too much to the point that the little vessels in the heart and the kidneys and the liver, they're failing. So like you're pushing them with too much pressors, but then you're not really getting the benefit of perfusion itself. It's a very, very delicate procedure. Now, they should be reserved for cases of persistent hypotension and tissue hyperperfusion after volume resuscitation has failed. Push dose pressors, the little phenylephrine that we give patients in the setting of acute onset of hypotension. I'm not going to wait for my norepinephrine to kick in. Maybe I can give them a little doses of phenylephrine. All right, we got about 10-15 minutes. We'll walk through some of the cases, and then we'll do some cool things about the epidemiology, and then we'll wrap it up for you guys. So you'll respond to a report of a 20-year-old female that was restrained a driver of a small car struck on the driver's side by a pickup truck. You see the mechanism of action? You see how it happened? Did she have a seatbelt on? Where the airbags were deployed? All these questions are necessary. There is significant intrusion on the driver's side. Okay. Now, your patient is alert and oriented, thankfully. She's a little bit anxious, a little bit of tremors. She is going through a whole, emotional stress. She complained of pain on the left side. What left side? We'll see. Now, there is no obvious bleeding. She has a good radial pulses and also good leg pulses or pedal pulses. Now, her skin is cool and dry. You extricate your patient into a backboard, and then her first set of vital signs are blood pressure is 136/86. I like the number. But the heart rate, 132. The respiratory rate is 20. All right. Is this patient in shock? That will be the first question that you have to ask yourself after you get those vital signs. You have to evaluate the clinical findings. You have to evaluate your vital signs, and then the clinical picture. So clinical findings, I got cool skin, I got dry, I got tachycardia. So what do you guys think? Maybe obstructive, maybe hemorrhagic, maybe a shock. These are all thought processes that you have in your head. So yes, she actually might be in a shock. While her blood pressure is normal, the mechanism of injury is very significant, and her elevated heart rate with cool skin are actually concerning. That's what I want you to have. So as soon as you arrive, you're presenting the patient as like, oh, blah, 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 was in a car accident, we extricated, we put a cervical collar on, vitals of this. And then give me a little bit of your thought process. This patient has cool skin. This patient is tachycardic. This patient was in a car accident. Boom, boom, boom. Now, over the next few minutes, the patient actually becomes slightly restless, and then she started complaining that she's having shortness of breath. Her vital signs now are still 132/90, but her heart rate is even more now, 144. And her respiratory rate is 22. And her skin is even worse, cool and damp. Now, what do you think is happening? Is she deteriorating? Is she actually transitioning to shock? Although she's still not hypotensive, the patient is clearly progressing down the shock pathway. That is the pathway that I want you to early recognize it, because it can happen to you while she's in the ambulance. It doesn't have to happen while she's in my emergency department. Now, she may be bleeding from a lacerated spleen that you're not aware of as an internal bleed. Maybe a fractured pelvis. Maybe other injuries that led to the shock of the low of the blood volume. Early recognition and treatment can be a life-saving. So you put that cervical collar on, you stabilize the fracture, you make sure that you're not missing any bleeding, do your due diligence, get their clothes out, look at their body, see where the bruise is, see where the bleeding is, and put a tamponade on it. In addition to a backboard, a C-collar, and a rapid extrication, she needs a pelvic wrap. Don't forget about the blankets. They're no joke. Remember hypothermia. Remember the triad of death that we talked about. Temperature is key. Get those blankets. Conserve the warmth. Give them oxygen. Do your ALS treatment. Get that IV fluid going. Get that IV on. Don't wait until you come to my department and then my nurses need to put IV in. You're serious. Rapid transport to trauma center. That's always part of the process. Next, we got time. You're called to a nursing home to evaluate an 80-year-old male. He's 80, you guys. So you got dementia and you got every single medical problem in the paperwork that you bring me. So thank you. Now, with a decreased altered mental status and orientation, holy crap, is that their baseline? I don't know. Who is normally alert and alert times 3. Okay, good. We got a baseline. Has been increasingly confused over the past 24 hours. Now, today, he is not going to wake up to have their breakfast. So the nurse calls you and be like, hey, this patient is not acting well. They're not their normal selves. They're not their usual selves. That's what they're actually going to tell me. Now, the patient has a history of hypertension and they got strokes and previous UTIs in the past. So these are little things, hypertension, diabetes, previous history of stroke, and got UTIs and pneumonias in the past. All these things, they get thrown at you. You can think of underlying sepsis, maybe. You can think of an underlying dehydration. You can think of hypovolemia. I want you to think about these things when you see those old people at the nursing facilities. You find the patient lying in bed as soon as you walk into the room. And I walked with you guys into those nursing facilities. It's daunting. It's one of those situations that you'll be like, all right, let's just transport them. But while you're transporting them, look at them, observe them, because I want that observation. You are my eyes in the field. He opens his eyes when you touch him, but does not speak and does not follow commands. His vitals, 88/54. Oh God. Heart rate is 148 and respiratory rate is 26. Yeah, that's not good. His skin is flushed and it's hot to touch. Now, what is the cause of the patient's shock? I'm asking what is the cause. I'm not asking is that patient in shock, because that patient is obviously in shock. You need to get that by now. And you need to understand that you have to look further. What is the cause of the shock? Is the cause infection? Is the cause dehydration? I want you guys to think. Based on the previous history, he may actually have a UTI. He may have a pneumonia. He may have an untreated bacteria that can actually invade the bloodstream and produce toxins that damage the cells throughout the body, causing leaky vessels and loss of ability to constrict, vasodilation, drop in the blood pressure. That loss of systemic vascular resistance leads to a drop in the blood pressure. So think about why they're losing blood. They're not like, oh, I'm hypotensive because I'm losing blood. No, I'm hypotensive because I have a sepsis infection. So you give them a little bit of fluid, that's great, but remember that this is not the answer. Fever often accompanies septic shock, and when it gets to fever, that's basically the beginning phase. However, as the body system begins to break down, the temperature often falls. But they might not have a fever at all because they might just be on a Tylenol every day, or like hydrocodone mixed with Tylenol. So when you get vital signs on them and then you don't find fever, it's like, oh yeah, hey, Dr. Jamal, this patient does not have shock. Just because they don't have a fever, that does not necessarily mean that you're not actually experiencing a shock. Some septic patients can actually present with hypothermia. Septic shock is as much of an emergency as hypovolemic shock. So just because they're not losing blood, that does not necessarily mean that you can chill about that patient. Patient needs prompt transportation to a facility that provides them with IV fluids, vasopressors, antibiotics, and they have capability to put the patients in the ICU so we can continue monitoring them very, very closely. All right. Now, some of the epidemiology that I really appreciate is that the population-wide incidence of a shock is actually 76 per 100,000 person per year. And it's more common in men, older patients, rural settings, and those with a lower socioeconomic status. It is part of the process, you guys. It's part of the epidemiology that we need to understand what kind of population that we're dealing with. What is our statistics when it comes to sepsis, and what can we do to prevent those statistics from increasing in the future? Distributive shock is actually the most common type of shock. Can you believe that? It's not hypovolemic, it's not hemorrhagic, it's actually septic shock, followed by hypovolemia and cardiogenic shock. And then you got your obstructive shock, which is relatively less common. It's like not every day that I put a chest tube in a tension pneumothorax, not every day that I put a needle in their heart to get a pericardiocentesis out of the way. So that's kind of why it's less common. The most common type of distributive shock is septic shock and has a mortality rate between 40 and 50%. That's crazy. So if we do not recognize it early, if we do not have treatment, initial treatment earlier, we are going to miss on that, and they're going to have increased mortality rate. So my conclusion for this slides and the whole presentation, I really hope you guys understand where I'm coming from. I really hope that you guys have a concept of shock more better than before. You got a proper presentation of how the patient present to you. You are thinking further and further about the next steps, because it's all about the next steps, and how you present it to me in my emergency department makes a big difference. I am dealing with so many patients in my department that when I come to you and I actually ask you for presentation, you make sure you provide me with those information if you can, because you're going to help me out. So early and accurate identification of the patient's stage and type of shock is essential in managing patient's condition. Always remember that. Next time you see me, tell me that, hey, I think this patient is in shock, and I think that this patient has a septic shock. Thank you for telling me that. Sound clinical reasoning skills, a thorough assessment, and a careful but expedient interpretation of the diagnostic findings are necessary to provide effective treatment for the patient who is in shock. And if you do that, you're going to do the patient a favor, you're going to do yourself a favor, and you're going to do me a favor. With that being said, I really appreciate you guys listening to my presentation, hearing about shock, hearing about the differentials of shock, and how we can save lives in the future. Any questions?
I did not see any questions. A whole lot of thank yous. Is that what you're saying here, Jeff?
Yes, sir.
I'm sure I didn't miss any of that.
Smiley face.
What's that?
Smiley face.
Smiley face. I like it. Smiley face it is.
I mean, I wouldn't expect anything different for Jamal. 'Cause
Appreciate it.
That's just how I feel with him.
Thank you. Thank you.
Thank you.
Always
Very
happy to
informative.
smile.
Very
It's for you.
informative.
Appreciate it.
Thank you. Let me
Hold
get
on.
your presentation now.
Thank you. Thank you.
All good? All good?
All right.
I'm going to shut the microphone off. All right, everybody, we'll wrap this one up and be back in a few minutes for our final presentation of the day. See you here in about 8 minutes.